Okay, we are going to go ahead and get started. Good evening, and thank you for joining us for the first program in the Leukemia Research Foundation's New and Emerging Treatments Conference. Tonight's program will focus on CLL and NHL. My name is Carrie Callis, and I'm the Director of Programs at the Leukemia Research Foundation. I would like to take a moment to thank our supporters of this program: AbbVie, ADC Therapeutics, Bristol Myers Squibb, Incyte, Janssen Oncology, and Novartis Oncology. We also want to thank our moderator, Dr. Stiff, and our presenters tonight, Dr. Venugopal and Dr. Kline, for sharing their time and expertise this evening. As a brief background about the Leukemia Research Foundation, the Foundation's mission is to conquer all blood cancers by funding research into their causes and cures and enriching the quality of life of those touched by these diseases. Since its inception, the Foundation has raised over $80 million in support of its mission, funding over 600 research projects worldwide and supporting patients and families living with a blood cancer diagnosis through several programs, including educational conferences and webinars, peer support programs, financial assistance, and patient resources. I encourage you to visit allbloodcancers.org to learn more. Just a few quick housekeeping items for the program tonight. We will cover both topics, and it will then be followed by a question and answer session at the end. All participants will be muted throughout the program, but you will be able to ask questions by typing them into the Q&A box at the bottom of your screen at any time during the program. If you already submitted a question during registration, rest assured we have those questions and we'll include them in the Q&A. After today's program, you will be sent a very brief evaluation through email, so please take just a moment to complete the evaluation so we can improve our future programs. Also, this program will be recorded and be made available to all participants. At this time, I would like to introduce our moderator of tonight's program, Dr. Patrick Stiff from the Cardinal Bernardine Cancer Center at Loyola. Dr. Stiff is the chair of the Leukemia Research Foundation's Medical Advisory Board, and we thank him for all he does to advise and support our work at the foundation.
Thank you, Carrie. Good evening, everybody. And I'm glad to be here with our two presenters and appreciate the introduction, Carrie. This conference actually began as an in-person conference approximately 15 years ago with the help of the Leukemia Research Foundation, Loyola University, and the National Marrow Donor Program. And we had well-attended conferences on a yearly basis until COVID. Now we're forced to come to you through the black box of the computer or phone or tablet that you are looking at us right now. It's okay, but not ideal. I think as physicians, all of us really enjoy the interaction we have on a daily basis with patients and families. Not 100% of the time, because things sometimes go as unexpectedly to areas of complications and relapses, etc. But we're delighted to interact with patients face to face on a regular basis. So as we participate in this, be aware that this is not our choice, and I'm sure it's not your choice. But what is unique is that rather than just the Chicago area, we're able to come to folks all over the country who are supporters of the Leukemia Research Foundation. So this is actually the first of 3 programs. There's going to be an additional program on October 27th in the evening again, where we're going to talk about multiple myeloma and CAR T cells. So we're really not going to address CAR T cell therapy for the 2 diseases we're talking about tonight. And then on November 10th, acute myeloid leukemia and the emerging area of being able to measure minimal residual disease, or those patients who are more likely to relapse down the line. Again, as Carrie mentioned, we're going to give presentations back to back without stopping, and then have questions and answers at the end. Now, in the bottom of your screen, there's a chat box. We're not going to be using that tonight. And then there's a question and answer box where you can type in additional questions, and we'll be addressing as many of those as possible during the Q&A session. So without further ado, I'd like to first introduce Dr. Venugopal from Rush University Medical Center. He's the Alodia Chem Chair of Hematology. He's Professor, Division of Hematology Oncology at Rush University Medical Center and Director of the Section of Hematology. Dr. Venugopal is well known to patients and physicians in the Chicagoland area, and in fact, throughout the Midwest and nationally. His areas of research have been more in the lymphomas and chronic leukemias, but does have a diverse background and experience in treating all patients with blood cancers, as well as benign blood disorders. So without further ado, he's going to talk about chronic lymphocytic leukemia, one of the major illnesses, in fact, the most common adult leukemia, and talk about some of the new advances that we've seen in the last several years in this area. Dr. Venugopal. And I hope that, Carrie, you're going to be putting his slides on, right?
Carrie, can you hear me?
Yes, I can hear you. We can hear you.
Yeah, I think
Are you
my
having
screen sharing is disabled, so maybe you have to pull it up.
Okay. I will share it for you. Hang on one moment. All right.
I think it is working now. Can you see the screen?
Yes.
So click at the lower thing on the right side where it has the different boxes all the way over, one more over to the right, right? No, this one right next to the one you were on, two over, 1, 2, there you go. Click on that one.
Yeah, but
There we
that's
go.
not working. Yeah.
There we go.
But Carrie, I don't know if I am able to control the slides.
Well,
Yeah, you can just let me know when to advance. I'll go ahead and do it for you.
Okay. Very good. Okay, I'll start then. Thank you. Thank you, Dr. Stiff, for that kind introduction. And thank you, Carrie, for organizing this meeting. This is something I have always enjoyed. And every time I get an opportunity, I have always jumped on it. And thanks again. Welcome, everyone. So over the next 20 minutes or so, as Dr. Stiff said, I will be talking on chronic lymphocytic leukemia. And next slide. The first few slides, I will talk about some of the basic facts about CLL, chronic lymphocytic leukemia, which most of you know very well, but I will still go over these. And then most of my talk will be on the new developments, particularly some of the new developments in treatment. As you know, CLL is the most common adult leukemia. Dr. Stiff just mentioned that. In 2021, we expect about 21,250 new cases in the US. And you can see that more than 87% of these patients will be living more than 5 years. And this number will vary depending on the various prognostic factors, which I will go into in the next few slides. In the bottom, you can see that the death rate is declining over the years and decades, slowly but steadily. And there are various factors contributing to this improvement in death rate, particularly improvement in the supportive care we give these patients, as well as the newer diagnostic methods and new treatment options, some of which we will be talking today. Next. Okay, how is CLL diagnosed? Next slide. So the typical story is that the patient goes to primary care physician for a routine physical exam, and the white blood cell count was found to be high. And that leads to some intervention. Sometimes the physician may decide to give a course of antibiotic because increase in white cell count is commonly caused by an infection. But in any case, ultimately the patient ends up with a hematologist who does some additional workup. And most of the time, blood test itself can confirm the diagnosis. This is a blood smear. We look under the microscope. You can see these cells. Many of them are lymphocytes, but some of them are leukemia cells as well. In order to distinguish between normal lymphocytes and leukemic lymphocytes, we looked at the proteins that are expressed on the leukemia cells, on the cells, by a test called flow cytometry. Carrie, next slide. Yeah, so you see this term flow cytometry is something very commonly done, and that's a test that usually confirms the diagnosis of CLL, essentially looking at different proteins that are expressed on the surface of the cells. And once the diagnosis is confirmed, the hematologist or the oncologist you are seeing will do a variety of tests depending on the prognostic factors they're looking for, as well as if there is treatment needed, there may be additional tests. Next slide. One of the questions that comes very often with a new diagnosis of CLL is, what is my prognosis? Prognosis is established by many factors, including some of them that are listed in the next slide. Harry? So you see a list of prognostic factors on the left side, starting with CD38 is a protein that is expressed on the cell surface. If it is higher, they do not do that well compared to patients who have low CD38 expression. Like that, there are several of them you can see in the list. And one of the important ones I want to emphasize is the FISH test, that is FISH or FISH stands for fluorescent in situ hybridization, by which you can pick up abnormal chromosome in the leukemic cell. Similarly, gene mutation, which is the last line, you see some of the gene mutations which are important in CLL, starting with the first one, TP53, which corresponds to the deletion of 17th chromosome. And that is a very important adverse prognostic factor. And it is not only important in prognosis, but also in identifying appropriate treatment or excluding certain treatment options. This is very important. Next. To show, so these are some of the terms you will be discussing with your doctor. Chromosomes, FISH, which I just mentioned. PCR is looking at these abnormalities at a much deeper level, polymerase chain reaction test. Mutation analysis, and NGS is another term you will hear, next generation sequencing, which typically looks at a large number of genes looking for mutations, which can also help not only in prognosis, again, in determining the appropriate treatment. Next slide. As an example, this is a slide showing the importance of prognostic value of FISH, or fluorescent in situ hybridization. You can see the graph on the right side, where the red line represents patients who have normal chromosome pattern in the leukemic cells, compared to the green line, which are patients who have the 17th chromosome abnormality deletion in their leukemia cells. You can see that when you have 17p deletion in the leukemia cells, the survival is inferior compared to the other abnormalities. So this is the reason why FISH test is an important prognostic factor. Next slide. So what are the indications for starting treatment? Because typically most of the patients who are diagnosed with the CLL do not need treatment right away. They are observed for a period of time, which may be months and typically a few years before they need treatment. So you need to know what are the indications for treatment that your doctor will be looking for to advise you to initiate treatment. Next. So these are some of the accepted indications for treatment. I don't go into the whole thing, but just to give you an example, the first bullet point, constitutional symptoms. So if you develop symptoms related to CLL, like fever, weight loss, night sweats, of course, the doctor will investigate for other reasons for these symptoms. If they cannot find anything, then CLL is the most likely cause and treatment is indicated. Or if you have progressive marrow failure, that means the leukemia cells are accumulating in your bone marrow so that the normal blood formation is affected and your blood counts go down, you become more anemic, your platelet count go down, putting you at higher risk for bleeding. That is another typical indication for starting treatment. Now, if your doctor decided to start treatment and you were advised and you agree, what are the treatment options for a newly diagnosed CLL patient? Next. So again, the point in this slide before I move to the next one is observation is appropriate in the absence of indication for treatment. Next slide. So these are some of the treatment options for first line, that is the first time treatment. Chemotherapy has been the standard of care for a number of years and decades, but now we use it much less because of the advent of more targeted treatments, which I'll be talking on the next several slides. Monoclonal antibodies like rituximab, Gazyva, these are names I'm sure familiar to you. They are mostly part of the combinations we use nowadays. Chemotherapy combinations with antibody like FCR or BR used to be very popular, but now we use it much less commonly, especially in the front line because of the advent of other treatment options. Ibrutinib, acalabrutinib are BTK inhibitor drugs, which we will talk about in the next several slides. Venetoclax is a very important option again. And finally, clinical trials. I cannot emphasize more the importance of clinical trials because these are the trials that brought us these newer treatment options, and we should continue to get into clinical trials whenever possible. Next slide. This gives you an idea of the new agents that came into the market in the last 1 decade, starting in 2013, when Imbruvica or ibrutinib was first approved. So ibrutinib and acalabrutinib are BTK inhibitors approved for CLL treatment. Similarly, obinutuzumab and ofatumumab are newer rituximab-like monoclonal antibodies. Idelalisib and duvelisib are oral agents which work by inhibiting a pathway called PI3 kinase in the leukemia cells. And venetoclax is a BCL2 inhibitor. We will talk about it, even that's also an oral agent, very effective in this disease. CAR T cells, which Dr. Stiff briefly mentioned in his introduction, is an exciting treatment in many blood cancers, and it has been approved in different types of lymphomas and leukemias, but not yet in CLL. There's a lot of trials going on looking at the role of CAR T in CLL, and hopefully we get it approved in the near future. Next slide. This is a cartoon to show that many of the targets in the leukemia cell is what these new agents target. And I'm going to talk about it. So next slide. Yeah, BTK is one of the pathways you can see in red in the center of this diagram. I'm sorry, I can't use a pointer. And this is a pathway which is very important in the survival of the CLL leukemia cells. And that's why inhibition of this pathway can lead on to specifically targeted killing of the leukemia cells without affecting the normal cells. And that is why this BTK inhibition is significant in CLL treatment. Next slide. This lists 3 of the BTK inhibitors that are in the market. Ibrutinib and acalabrutinib are FDA approved for CLL, and zanubrutinib is not yet approved. It is approved for mantle cell lymphoma and 2 other diseases. Now, between the 2 drugs that are approved, ibrutinib and acalabrutinib, ibrutinib is taken once a day and acalabrutinib is taken twice a day. There are some differences in the side effects as mentioned below, which I can go over later on if there are questions. Next slide. So this slide shows you the longest data or follow-up data we have with BTK inhibitor, 8 years. And this is with ibrutinib because that was the first one that was approved. On the left, you see PFS or progression-free survival. That means how long the patient lives without the disease growing back. That is PFS. And overall survival means how long the patient lives after initiation of treatment. You can see that majority of patients, to be exact, 83% of patients had disease control after 7 years on this oral agent, which is quite impressive. We never achieved something like this with CLL before the advent of this drug. Next slide. And this is a trial comparing ibrutinib with chlorambucil, which used to be the chemotherapy pill we have used for a long time. Now we rarely, if at all, use this drug. Again, to show that compared to what was standard of care, ibrutinib has been very effective in these patients. Next slide. Next. So in 2019, there were 3 major studies, reports of which came and dramatically improved our ability to use these agents in CLL. Next slide. And next slide. So the first one is obinutuzumab or Gazyva, which is a newer rituximab in combination with ibrutinib or chlorambucil. So you can see in this graph here, the blue line represents ibrutinib with antibody, and the black line represents chlorambucil with antibody. And you can see that ibrutinib combination has significantly improved the PFS or the time the patient's CLL was in control compared to patients who received chlorambucil antibody combination. And on the right side, you see that the PFS was better even in patients with high-risk disease like chromosome abnormalities we mentioned. Next line. Next slide. So this was the first non-chemotherapy combination that was approved by FDA in January of 2019. That opens our gateway to the novel agent therapy even outside clinical trials. Next slide. And then the combination of ibrutinib with antibody was compared to what was standard of care before, that is chemotherapy like FCR. And you can see in the graph here, PFS and OS, both of them were better with ibrutinib with Rituxan compared to the standard FCR chemoimmunotherapy. Next slide. Ibrutinib plus rituximab leads to better disease control and survival compared to chemotherapy regimen FCR. Next slide. Similarly, the combination of ibrutinib was compared to the second more commonly used chemotherapy, that is bendamustine rituximab. Same story. You can see here whether you use ibrutinib alone or in combination with rituximab, both are better than bendamustine and rituximab. You can see it on the left side. Next slide. So ibrutinib rituximab combination leads to better disease control compared to bendamustine and rituximab. That's a message from this study. Next slide. Okay, how about relapse CLL. Many of the drugs listed here are combinations and single agents we talked about in the front line. Now, chemotherapy is used in some situations in CLL, in the relapse setting also, especially when the novel agents have not worked or the benefit from novel agents have been shorter than what is expected. And I added stem cell transplant here, which is very important option in patients with the relapse CLL, particularly if they relapse short term after the novel therapy. Stem cell transplant from a donor is also an important treatment option for CLL as a first-line treatment, especially in younger, healthier patients who have high-risk disease like the 17th chromosome abnormality we talked about. Next slide. So this is a treatment option which is very good in patients with relapse disease also. As you see here, ibrutinib was compared to the antibody of atumalimab in patients with the relapse CLL. And as you see on the graph on the left side, the disease control was significantly better with ibrutinib compared to the antibody. And overall survival also was equally effective, maybe slightly better with the ibrutinib. Next slide. And the second generation BTK inhibitor, acalabrutinib or Calquence, this is the data with single agent where they compared acalabrutinib with some of the standard options like bendamustine rituximab or idelalisib rituximab, which is an approved combination. And what was the result? As you can see in the graph, the combination of idelalisib and rituximab as well as bendamustine rituximab was inferior. Acalabrutinib did much better in controlling the disease. Next slide. There are trials going on comparing the ibrutinib, the first generation BTK inhibitor, with the newer BTK inhibitor. For example, this is a trial comparing ibrutinib and acalabrutinib. And this trial, at least the preliminary study, preliminary results that was presented showed that the drugs are equally effective. Acalabrutinib works equally well as ibrutinib, but with lesser side effects. But longer term follow-up will be needed to confirm this, and that study, that follow-up is ongoing. Similarly, next slide. The most recently approved BTK inhibitor, zanubrutinib, is being compared to ibrutinib. We know from comparison in other disease states that zanubrutinib may be equally effective like ibrutinib with less side effect, but CLL trials are ongoing. Next slide. To summarize, BTK inhibitors are a very important part of treatment of CLL. And again, as I showed before, both ibrutinib and acalabrutinib are very effective in this disease as single agent or in combination and compared to the standard of care treatment options. Next slide. Next slide. Okay, venetoclax, as I mentioned, is a very important option for patients with CLL. This works with a different mechanism. It inhibits the production of a protein called BCL2, which is very important in the survival of leukemia cells in CLL. As you can see in this data, majority of patients, close to 80% of the patients respond. And even in patients with that high-risk chromosome 17p deletion, you can see more 70% of the patients respond. Next slide. And venetoclax has been combined with rituximab, as you can see in this study, where they compared the combination with standard bendamustine and rituximab showed, and the disease control is significantly better with the venetoclax combination compared to bendamustine combination. Next slide. So venetoclax plus rituximab leads to better disease control compared to standard bendamustine rituximab chemotherapy. Next slide. This is the combination, again, venetoclax with the newer rituximab, obinutuzumab, showing that if you look at the graph that is shown below, venetoclax combination did significantly better than the chlorambucil combination. And if you look at the right side, the bar diagram, you see that the complete remissions are much more with venetoclax combination compared to chlorambucil combination. And we know that patients who achieve complete remission live longer with the better disease control compared to patients who do not achieve complete remission. So the fact that this combination was able to achieve more complete remissions is important in the outcome of these patients. Next slide. So this combination was approved by FDA in May of 2019 for treatment of patients with the CLL, SLL. Next slide. So with that, I want to summarize what I talked over the past 20 plus minutes. One thing I wanted to emphasize the significant improvement in not only the diagnosis and prognostication, but also in treatment of patients that have happened in CLL in the last decade. As you saw, the improvements have been dramatic. We changed the paradigm of treatment from chemoimmunotherapy to more targeted treatment, combination treatments. I emphasize the importance of personalized therapy, and this personalized therapy should be based on patient characteristics as well as the disease characteristics. And you saw the non-chemotherapy treatment options now we have for first line as well as subsequent treatment. Again, to emphasize, encourage participation in clinical trials, because without that, none of these would have happened this field. So with that, I will stop, and thank you again for your attention.
Thank you, Dr. Venugopal, for this very interesting talk, and don't go away because we have lots of questions for you. Next, Justin Kline will be speaking on non-Hodgkin's lymphoma. Justin is Associate Professor of Medicine and Director of the Lymphoma Program at the University of Chicago. He's a clinical and laboratory investigator. In the laboratory, he's looking at developing treatments to overcome immune resistance to cancers with the goal of developing new approaches to use with the intent of curing patients with these diseases. Again, tonight, he's going to talk about non-Hodgkin's lymphoma. And again, I've been asked to remind you that you can submit questions through the Q&A box at the bottom of your screen. Sometimes it disappears and you just kind of wiggle your cursor over the bottom of your screen there and click on the Q&A, and then you can submit any additional questions that you might have after or during the presentations. With no further ado, welcome, Justin, and again, thanks for sharing your expertise tonight. And you're muted.
You're darn right I am. Thanks for the introduction, Pat. Vinu, it's good to see you. Carrie as well. Let me, oh, you've got screen sharing disabled, so you want to pull up my slides as well, Carrie. On a personal note, I've been working with Pat and the LRF now for a number of years. The LRF has not only provided important research funding for me in my lab when I was getting started, but also is a great resource to patients and their families, who are battling blood cancers. So over the next 20 minutes or so, I'm going to talk about non-Hodgkin lymphomas, particularly focusing on treatment updates. And we're going to focus on three major lymphoma subtypes: diffuse large B-cell lymphoma, mantle cell lymphoma, and follicular lymphoma. There are many, many, many different types of non-Hodgkin lymphomas. Next slide. And so I'm not going to be able to cover them all in 20 minutes, but certainly look forward to hearing your questions about these and other lymphoma subtypes and their treatment. And so as I mentioned, non-Hodgkin lymphomas, which are basically cancers of immune cells called T cells and B cells, come in many types. As you can see from the pie chart here, they are numerous. The most common form of non-Hodgkin lymphoma is a B-cell lymphoma that is aggressive. That's called diffuse large B-cell lymphoma. And that comprises about a third of all non-Hodgkin lymphoma diagnoses. And that's followed closely by follicular lymphoma, which is a more slow growing type of B-cell non-Hodgkin lymphoma. And then a number of other varieties sort of smattered in here. But given the complexity of non-Hodgkin lymphomas, of which there have been roughly 60 different subtypes identified, I like to group them into buckets. And the first bucket are lymphomas that are indolent. And these include follicular lymphoma, which I've already mentioned, as well as chronic lymphocytic leukemia, small lymphocytic lymphoma, which you just heard about from Dr. Venugopal. There are aggressive lymphomas in the second bucket, and these include diseases like diffuse large B-cell lymphoma, as well as mantle cell lymphoma. And then there are less common and highly aggressive lymphomas. Sort of the classical one would be Burkitt lymphoma. Next slide. All right, so let's start by talking about diffuse large B-cell lymphoma. It is the most common form of non-Hodgkin lymphoma. It's an aggressive disease. The goal of treatment is to cure it. And for many years, since I've been doing this, the standard treatment for most patients has been a cocktail of chemotherapies, an immunotherapy, and a corticosteroid called R-CHOP. And each of those letters stands for a different drug in the regimen. The R is rituximab, and that's an antibody to which Dr. Venugopal alluded. And this is an antibody that helps your immune system recognize and kill lymphoma cells. The next three letters, the C, H, and O, are cyclophosphamide, hydroxydoxorubicin, also known as doxorubicin or adriamycin. The O is a chemotherapy medicine called Oncovin, also known as vincristine. And the P is a steroid or a corticosteroid medicine called prednisone. And this cocktail is administered about every 3 weeks. And depending on the stage and other factors, somewhere between 3 and 6 treatments. As I mentioned, this is a very effective treatment and leads to the cure of diffuse large B-cell lymphoma in most patients, approximately 65% of all comers. But for those with early stage limited diffuse large B-cell lymphoma, cure rates are as high as close to 90%. Now, there have been many attempts over the years to improve upon the R-CHOP treatment backbone, all of which have failed in large part, which has been disappointing. And I'll talk about a new cocktail that may have just beaten R-CHOP. And so R-CHOP remains the standard treatment for most people with diffuse large B-cell lymphoma. However, we do sometimes use more aggressive CHOP-like regimens for uncommon subtypes of diffuse large B-cell lymphoma, such as primary mediastinal B-cell lymphoma, which is an aggressive lymphoma that's often diagnosed in young people, as well as double hit lymphomas, which some of you may have heard of. Next slide. So let's talk about early stage diffuse large B-cell lymphoma. And this would be diffuse large B-cell lymphoma that's stage 1 or stage 2, meaning one or a couple of lymph node groups being involved with the lymphoma on the same side of the breathing muscle called the diaphragm. And until recently, the treatment of early stage diffuse large B-cell lymphoma was either with an abbreviated or shortened course of R-CHOP for 3 to 4 cycles, followed by radiation to the sites of the body where the disease was initially diagnosed. Alternatively, some doctors preferred to avoid radiation and to give a full course of 6 treatments of R-CHOP chemotherapy. However, over the past few years, there have been a couple of studies that suggest that we can achieve very good outcomes without radiation treatments. And the reason this is important is because radiation can sometimes have unwanted long-term side effects, damage to organs, as well as a risk for developing secondary cancers in the area of the body that was radiated. And the first study was called the FLIER study, and this was a German study that compared 6 treatments of R-CHOP to 4 cycles of R-CHOP and 2 doses of rituximab And here they included younger patients with very early stage, low risk diffuse large B-cell lymphoma. But what they found was that the outcomes, which were both very good, were identical regardless of whether patients received 4 or 6 cycles of R-CHOP. And so from this study, we can conclude that we can get away with treating very low risk, early stage diffuse large B-cell lymphomas with 4 cycles of R-CHOP rather than 6. And the second study was called the S1001 study, not important for you to remember that at all. And this was a what's called a PET adapted approach. And so patients received 3 cycles of R-CHOP treatment, and then they had a PET scan to see how their lymphoma responded. And the 85% of patients who had a negative PET scan, so by far and away most patients, received a 4th and final cycle of R-CHOP. Alternatively, the patients that had positive PET scans after 3 treatments, about 15%, went on to receive radiation therapy, as well as another type of therapy that's not used very much anymore called radioimmunotherapy. But regardless, for patients that were PET negative or their PET scan was clean after 3 cycles of treatment, the 4th treatment of R-CHOP was associated with a very good outcome. Again, suggesting that we don't need to use radiation in most patients with early stage diffuse large B-cell lymphoma which is great. One exception might be for folks who have very large early stage tumors, where we might be more likely to recommend radiation. And so to sort of summarize, in the first line treatment of diffuse large B-cell lymphoma, for folks who have advanced stage 3 and stage 4 lymphoma, we're still using 6 cycles of R-CHOP. But for folks with early stage 1 or stage 2 diffuse large B-cell lymphoma, we can often get away with less intense treatment. Next slide. As I mentioned, the standard treatment today for advanced diffuse large B-cell lymphoma, stage 3 and stage 4, is 6 cycles of R-CHOP for most patients. However, there was a recent press release from a pharmaceutical company called Genentech that had sponsored a very large randomized study called the Polarix trial, where they randomized about 900 patients to receive the standard, which is R-CHOP for 6 treatments, or 6 cycles of R-CHP minus the O, that Oncovin or vincristine drug, that was substituted for a new type of therapy called polatuzumab. And what we hear from this press release is that the latter treatment, the treatment with 6 cycles of R-CHP plus polatuzumab, was superior with regard to prolonging the remission rates of patients that were on that arm. And polatuzumab is in a class of more and more commonly used medicines in lymphoma and other diseases called antibody drug conjugates. And I have a little cartoon here on the bottom, but what you can see is that these antibodies, and in the case of polatuzumab, the antibody targets a protein on lymphoma cells called CD79, which is not important for you to remember. But on the back of that antibody is a chemotherapy drug. And so this is a fancy and targeted way of delivering chemotherapy specifically to lymphoma cells. And so we're going to hear more about this study at a big meeting coming up in December. But this is the first study in a long time in the first treatment of diffuse large B-cell lymphoma that may change what we do as oncologists. So this is really important. Next slide. Now, what about diffuse large B-cell lymphoma that either fails to go into remission after its initial treatment, or that does go into remission but comes back? And these are called relapsed or refractory diffuse large B-cell lymphomas. And for many, many years, the standard treatment for this situation has been to give an alternative chemotherapy to try to salvage a remission. In other words, to try to put the lymphoma back into remission. And so it's called salvage chemotherapy, followed by very high doses of chemotherapy and an autologous or self stem cell transplant using one's own stem cells. And for younger, fitter people who have lymphoma that's responsive to this salvage chemotherapy, this approach cures about 20 to 40% of patients. So it's decent, but not ideal. It's also a very intensive treatment. And so many people, including older people or people with lots of other health problems, as well as for folks whose lymphoma does not go into remission or does not respond well to the salvage chemotherapy treatments, this is not a good option. However, for these folks, CAR T cell therapy, which I'm going to talk more about in a few slides, may be in fact be an option. And there have been several new drugs and drug combinations approved by the FDA to treat folks who have diffuse large B-cell lymphomas that have returned or recurred, including polatuzumab, the drug I mentioned on the last slide, in combination with a chemotherapy called bendamustine, and that immunotherapy medicine called rituximab, and we call this Pola-BR. There's another combination called tafasitamab, which is an antibody against CD19, another immunotherapy, combined with an oral medicine called lenalidomide. And then a third option called loncastuximab tesirine. Of course, these medicines are all a mouthful. We call it Lonca. And this is another antibody drug conjugate like polatuzumab that targets a different protein on the lymphoma cells called CD19. And finally, another oral drug called selinexor has also been improved in this space. So we have more and more tools, if you will, to treat lymphomas that have come back after that initial R-CHOP therapy. Next slide, please. And so probably the biggest breakthrough in the treatment of recurrent or relapsed diffuse large B-cell lymphomas in the past 20 years has been CAR T-cell therapy. And this is a type of immune therapy where we collect the patient's own T cells, which are immune cells, from his or her blood. And then we use a virus to infect those cells and to confer upon them the ability to recognize and kill lymphoma cells based on a receptor called a chimeric antigen receptor, which targets that CD19 protein I mentioned on the last slide that's expressed on cancer B cells, and unfortunately also healthy B cells. And so the general approach to this treatment is shown in the cartoon on the right, where you have the person with lymphoma, his or her blood cells, including immune cells, are collected, and the T cells are activated in a dish. After they've been activated, they're infected with a virus that contains the genetic machinery that encodes the CAR, the chimeric antigen receptor. That chimeric antigen receptor, the CAR, is expressed on those T cells, which are grown up to very large numbers in the dish. They're sent back to the university or the hospital. The patient gets some chemotherapy ahead of time to sort of prepare the body to allow the CAR T cells to grow once they're put back in. And those CAR T cells are infused just like a blood transfusion. It takes about 15 minutes. Next slide. And so again, for folks that have large B-cell lymphoma that has come back after an autologous stem cell transplant, or that has been resistant to 2 prior treatments, there are now 3 FDA-approved CAR T products. I've listed them here. Again, it's not important for you to remember each of them. They all see or recognize the same target called CD19 again, that's expressed on most, if not all, diffuse large B-cell lymphomas, and is also expressed on other lymphoma cells. Their long-term effectiveness seems to be pretty similar, but the incidence of side effects that are unique to CAR T-cell therapy seem to differ a bit between each of these 3 products. And so what we know so far is that about 1/3 of people that receive CAR T-cell therapy for their relapsed diffuse large B-cell lymphoma have long-term remissions, and many are probably cured. Now, that being said, still, after CAR T-cell therapy, many patients have lymphomas that come back. And how best to treat these lymphomas is an area that is really under intense study these days. Next slide. And so, as I mentioned, currently CAR T-cell therapy is approved for folks that have had 2 or more prior treatments. However, 2 recent studies, one is called ZUMA-7, another called Transform. They've tested CAR T-cell therapy in the second line and compared the outcomes of folks that receive CAR T-cell therapy versus those that receive the salvage chemotherapy and autologous stem cell transplant. And again, through press releases, these studies have reported that perhaps CAR T-cell therapy is superior to what we've been doing for the past 2 decades, which is chemotherapy and stem cell transplant. So this data also is going to be shown very soon, but it really may change what we do in the treatment of diffuse large B-cell lymphoma in the second line of treatment. So there have been a couple of big breakthroughs, I would say, at least potentially, both in the initial treatment and in the treatment of relapsed diffuse large B-cell lymphoma. There are many drugs and immunotherapies that are being developed in diffuse large B-cell lymphoma. I don't have time to cover them all, but certainly happy to answer questions during the Q&A session. Next slide. And so what about mantle cell lymphoma? This is a much less common type of non-Hodgkin lymphoma. It's also a B-cell non-Hodgkin lymphoma. It's typically, although not always, an aggressive disease. And for younger patients who are healthy, the initial treatment is typically with aggressive chemotherapy and rituximab, followed by that autologous stem cell transplant procedure I mentioned earlier, and maintenance rituximab, where folks are getting rituximab every few months for 2 or 3 years. There's a very important clinical study going on across the country asking the question of whether people who've had a very good response to that initial aggressive treatment actually need a stem cell transplant, or whether they can simply go on to receive maintenance rituximab, which is much cheaper and associated with far fewer side effects. So we don't know the answer to that question yet, but that's a study that I would encourage folks to look into if they're looking for initial treatments for mantle cell lymphoma. Now, for older patients or for folks who have other health problems, initial treatments for mantle cell lymphoma are varied. Probably the most common that's used is bendamustine and rituximab, with or without another chemotherapy called cytarabine, which is commonly used and also very, very effective. Next slide. Now, for folks who've had mantle cell lymphoma that's come back after initial treatment, which is often unfortunately the case, drugs called BTK or Bruton's tyrosine kinase inhibitors that Dr. Venugopal mentioned in treatment of CLL. These drugs are also extremely effective in relapsed mantle cell lymphoma. As he mentioned, there are 3 BTK inhibitors approved. Most people who receive these treatments benefit, their lymphoma responds. And there's really doesn't seem to be an obvious difference with regard to effectiveness of any of these 3 agents, but certainly the newer BTK inhibitors, acalabrutinib and zanubrutinib, do seem to be associated with less side effects and maybe preferred. However, with these treatments that often work for a year or a few years, the major issue is resistance. So the lymphoma figures out a way to grow in the body despite these drugs. CAR T-cell therapy was also fairly recently approved for mantle cell lymphoma. Again, only in folks who have lymphoma that's become resistant to these BTK inhibitors. The treatment with CAR T-cells is extremely effective, very, very high response rates. But the treatment is certainly more involved and associated with quite a few side effects that we need to monitor for. And the durability, how long the response lasts after CAR T-cell therapy in mantle cell lymphoma is still somewhat of an open question. Next slide. And so in the last couple of minutes, we'll talk about follicular lymphoma. Again, this is the second most common type of non-Hodgkin lymphoma, also a B-cell lymphoma. And this is an indolent lymphoma. And as far as initial treatment, there are 2, maybe 3 standard initial treatments that we often use for folks with follicular lymphoma who need treatment. In other words, people that have symptoms from their lymphoma or have low blood counts as a result of their lymphoma. And they are bendamustine and rituximab, lenalidomide and rituximab, and sometimes R-CHOP, that same cocktail I talked to you about in the context of diffuse large B-cell lymphoma. Although because R-CHOP is more associated with more side effects, and it's not superior to the other options, it's become less and less commonly used. Now, with regard to BR and lenalidomide or Revlimid and rituximab, we call that R squared. They've been compared head to head. They are equivalent with regard to their effectiveness. They have different side effect profiles. Just because of ease, I think many oncologists prefer the bendamustine and rituximab, but they are from an effectiveness standpoint equivalent. The use of maintenance rituximab, again, giving rituximab after you finish the BR or the R squared initial treatment is controversial. Some doctors do it, others don't. We do know that giving this rituximab over the course of 2 years does improve response duration and the time until a person needs his or her next treatment. What it does not do, at least as far as we can tell, is change the end game. So although remissions induced with R squared or bendamustine rituximab are long, this is a disease that comes back most often. And so we're still searching for that curative treatment for this and other slow growing non-Hodgkin lymphomas. Next slide. What about in follicular lymphoma that has come back? What do we do there? Well, one important, I would say, relatively recent update is the identification of a group of patients with follicular lymphoma, about 20%, who get good initial treatment, but despite that, their disease comes back within the first 2 years of completing that treatment. And we call this progression of disease 24 in the business. And we know that these folks do less well. This is a high-risk group that may require new treatment approaches. And so identifying these folks and encouraging them to enroll in clinical trials so that we can figure out how best to treat them is really important toward improving their outcome. Now, as I mentioned, this seems to be a common theme. CAR T-cell therapy with Axi-cell or Yescarta has also been approved for follicular lymphoma based on a study called ZUMA-5 in folks who've received 2 or more prior treatments. Again, like mantle cell lymphoma and DLBCL or diffuse large B-cell lymphoma, the response rates are initially very high. But again, because we know follicular lymphoma is a disease that tends to come back late, we don't know how long these responses after CAR T-cell therapy are going to last in folks with follicular lymphoma. So it's very exciting, but we need longer follow-up from folks that were enrolled onto this and other clinical trials to know how effective CAR T-cell therapy is in this disease long-term. There's also been approval of a new oral drug called tazemetostat, which inhibits a protein that's often mutated and activated in follicular lymphoma called EZH2. I don't have time to go through the biology of how EZH2 contributes to lymphomagenesis, but nevertheless, this is a gene that's commonly mutated in follicular lymphoma. This is an oral therapy that's associated with pretty high response rates in folks who've had prior treatments for their follicular lymphoma, as well as a reasonable duration of response, roughly 10 to 12 months. And it's approved for patients with follicular lymphoma that carries an activating EZH2 mutation, as well as for follicular lymphoma patients where no other standard treatment or good standard treatment is available. So, this is a drug that by itself is not a huge game changer, but it's very well tolerated and is being explored in a large number of combinations with other drugs to see if that will improve not only the response rates, but also how long these drugs work. Next slide. And so again, just like the other lymphomas, there are many promising drugs and immune therapies that are under development for follicular lymphoma, including combinations with lenalidomide and tazemetostat, bispecific immunotherapy, which works similarly to CAR T-cell therapy, but a bit different approach. And another type of immunotherapy called CD47 blockade. So again, I don't have time to cover all of these, but I'm certainly happy to answer any questions you might have in the Q&A session, which we're just about to get to. And so I know you are all here, not necessarily to hear doctors drone on and on about these new options, but to ask questions that you have about your disease in particular. So with that, I think we can perhaps get there. Thanks for listening. And as I said, happy to answer any questions.
Great. Thank you very much, Justin. And again, thank you, Dr. Venugopal, for your insightful and easy to understand presentations. So let's just jump right into the questions and we'll start with the easy ones, okay? Dr. Venugopal, can CLL ever be cured?
That's a very important question. Well, in the past, we used to say that the only treatment that has cured CLL, which I have patients, 1 or 2, is those who have received a transplant from a donor. I think I mentioned in my talk, that's an option certainly available for certain patients with CLL, especially a patient who is young and healthy, can tolerate a procedure like a donor transplant, and has certain mutations, they can certainly, high-risk mutations, they can certainly be considered for allotransplant or in the lab setting. So to answer your question, yes, it can be cured, but allogenic stem cell transplant is the only cure that I have heard, except one other data would be patients who received FCR chemotherapy, for example, younger patients who have this IGVH mutation, which I showed you in the prognostic factors. If they have the IGHV mutation, and if they receive that chemotherapy 6 cycles of FCR, there is data to show that 10 to 15 years later, more than 60% of the patients did not have evidence of disease. So I think it is reasonable to assume that they are cured. That's the best answer I can give.
So why don't we use FCR?
FCR is number one, as I showed when they compared with the novel agents. Even the survival was inferior, and the thought was that it causes so much of bone marrow suppression, low counts, infections. That is one acute problem. But the long-term problem, FCR can lead on to long-term bone marrow damage and including acute leukemia. So those are things to be considered before we jump into FCR in the era of novel agents.
Great. Justin, similar question. You talked about diffuse large B-cell lymphoma being curable with upfront therapy or standard second-line therapy. But you also said that follicular lymphoma keeps coming back. So I'll ask you the same question. Can follicular lymphoma ever be cured?
Yeah, that is, I don't know how easy that is, but as Dr. Venugopal mentioned, typically we think of follicular lymphoma and its curability in the context of allogeneic stem cell transplantation. In other words, when you receive donor cells from, quote unquote, matched brother or sister. Certainly outside of that, and of course, that's a treatment that we rarely use in follicular lymphoma these days. But outside of that, certainly we all have patients with follicular lymphoma in our roster, if you will, who receive treatments such as bendamustine and rituximab or lenalidomide and rituximab, who have extremely long remission durations. Many of these folks are older and end up passing away of some other cause. And so the question is whether those folks are cured or not. But I'm not talking to patients who are receiving standard treatments like bendamustine or lenalidomide with as having curative potential, because I don't believe it's true. Why we can't cure these diseases, despite the fact that they're all very sensitive to the treatments, the standard treatments we use, I think is $1 million question.
So I guess what I'm hearing you both say is that, yes, there are curative therapies out there. They're potentially toxic and life-threatening, and that given the long natural history of these diseases with less intensive therapy, it may not be appropriate or necessary to cure somebody of their underlying disease. So I think that that's an important concept for patients to understand. Okay, we'll go into a little easier one, Dr. Venugopal. A patient asks, my white count and lymphocyte counts are elevated, but I have no symptoms, and my RI score is 0. How can I keep my disease under control and keep it from progressing, ever requiring therapy?
That's a very common question that patients ask. And I think the best answer I can give is just like the low-grade lymphoma Dr. Kline mentioned, CLL is also what we call as an indolent disease, a slow-growing disease, particularly, the patient you just talked about, RI stage 0, just white cell count elevation. So the point I'm trying to say is the immune system has a lot of influence on these diseases in terms of their rate of growth. So if you keep your health good, so in other words, I usually tell the patient, take care of your health very well, health maintenance. And if you keep your immune system well, that might help keeping the disease under control, but not any medication. I'm not aware of any intervention with a medication or supplement that could, facilitate that.
Okay, thank you. Next, for Justin, we've all seen the TV commercials for drugs like Opdivo and pembrolizumab and nivolumab on TV as being very effective for really bad cancers like lung cancer. Are those drugs ever used to treat lymphomas?
Yeah, Pat, that's a great question. So, certainly those drugs which work by activating T cells of our immune systems have really revolutionized the way many human cancers are treated, including a few lymphomas, such as Hodgkin lymphoma and that rare type of non-Hodgkin lymphoma I mentioned earlier called primary mediastinal B-cell lymphoma. However, in more common lymphomas like diffuse large B-cell lymphoma, follicular lymphoma, mantle cell lymphoma, their effectiveness is not very good. They're pretty well tolerated with regard to side effects, but maybe 5 to 15% of patients who receive these treatments will benefit. And so why that's the case is something that I certainly am interested in looking into, but as it stands now, these are not great treatments for most types of B-cell non-Hodgkin lymphoma.
Dr. Stiff, if I can make a comment on that. Obviously there are a lot of trials going on, and actually Dr. Kline, he's very modest. He is running one of the best trials looking at the effectiveness of this combination in lymphoma. I don't think he mentioned that.
Okay. Next, for Dr. Venugopal, you mentioned venetoclax as being a very effective drug for CLL. You've mentioned BTK inhibitors. Over time, can you talk about the possibility of one versus the other as being the best therapy for newly diagnosed patients?
Okay, so the question is between BTK inhibitors, which is a commonly used combination or option, and venetoclax, which is the other option. Is there a way we can select one over the other? I mean, certainly what we really need to answer that question is what we call as a head-to-head comparison, a well-controlled randomized study comparing the efficacy and the side effects of that. We don't have that data. So in the absence of that, I mean, there are trials going on looking at it, but in the absence of that, we can compare studies and looking at which is more effective or which is better in terms of side effects. We don't have that answer in terms of efficacy. Both these group of agents are very efficacious, but there may be some things based on which we might select one over the other. For example, if a patient has already atrial fibrillation or compromised cardiac function, you may want to avoid a BTK inhibitor, especially ibrutinib, which has a higher incidence of cardiac side effects. So like that, we can certainly, select based on some of the features. But as I said, again, there is no head-to-head comparison data to answer that question.
Vinu, if I might add one point, because this is a really, I'm sure in your clinic and mine as well, and question is, these are both great drugs. I think the one consideration that's important is the duration of treatment. Once you start a BTK inhibitor, you're married to it. And as you saw, these drugs work for a long period of time. And while side effects tend to get better over time, there's a reasonable discontinuation rate because of side effects like those Dr. Venugopal mentioned. The venetoclax option with obinutuzumab in that CLL14 study that Dr. Venu mentioned, the nice thing about it is that it's a time-limited treatment, excuse me. So folks are on treatment for roughly a year and then they're off. And so, I think that is the duration of treatment, the expense of treatment are also important considerations in frontline therapy when we have two drugs that are quite spectacular. My mother-in-law, for example, I hope she's not on, has been on ibrutinib for 7 years, has no side effects. It's fantastic, So I don't know if there's any one right answer, but these are other factors to consider.
Thank you. And also to mention, there is a study, in fact, there is 2 studies going on. looking at the combination of all three also, the Gazyva along with the BTK and BCL2 inhibitor versus not the combination. So I think that those studies, the results of those studies will answer the question which Dr. Kline just mentioned. Can we even abbreviate the therapy to a much shorter period and get the best benefit in the longest duration of remission?
Yes, those studies are separated by age, and one of the questions is what's an older patient? And in general, that depends on the study. We think of 65 and above, in some instances 70 and above in others. There was an older and a younger trial with some minor variations. The younger trial is completed, and so we're waiting for results of that. The older trial is still ongoing. Justin, you're next. We know that gene therapy is being done in a variety of diseases, including things like sickle cell disease. One of the viewers wanted to know, what about gene therapy for lymphomas?
Yeah, so gene therapy in the sense of, replacing a defective gene is, really a clever way to treat and hopefully cure diseases that are caused by one abnormal gene. Of course, lymphomas often have many genes that are altered or mutated, each of which contributes to a different degree to the lymphoma, its growth and survival. But I mentioned CAR T-cell therapy a number of times, and this is a type of gene therapy where we're using this CAR gene, if you will, that's put into a virus to enact or induce its expression on our own T cells that can then be put back into the body to help fight the lymphoma. So though we can't, through gene therapy, I don't see that as happening anytime in the very near future at all, directly manipulate the lymphoma cells through gene therapy. We can manipulate the immune system through gene therapy to affect better treatments, such as CAR T-cell therapy.
Okay. Dr. Venugopal, I am a CLL patient in therapy number 5 with Venclexta. What might be my next option? I have read there has been some success using interleukin-2 with venetoclax.
Yeah, I mean, certainly combinations with venetoclax should be something to explore. I think you will have to look into what exactly happened with the previous treatments. For example, when you say number 5 treatment, I'm assuming you had a BTK inhibitor. If you had a BTK inhibitor treatment, and if you came off the trial because of side effects, it is still worth trying the combination or a different BTK inhibitor. I think that's very important, because if you came off because of progression of the disease while you were on BTK, still you have an option. You can check for the mutation, and there are some new BTK inhibitors. There are many of them, but I think the most exciting is something called LOXO 305, which works in patients in whom the disease was refractory to BTK inhibitor also. I think those are certainly things that we look into. Plus, one should consider, I mean, depending on your age and health, experimental treatments like CAR-T or going back to allogeneic stem cell transplant should be considered at this point if you, are healthy to go through it and have an appropriate donor.
Okay, Justin, Dr. Kline, why is it not feasible to treat follicular lymphoma with phase 1 or 2 trials at the onset of disease?
Well, I wouldn't say that's never an option. And I think because of the long natural history of follicular lymphoma, people are surviving for, on average 15 years and longer. I think this is a disease that lends itself well to considering these investigational drugs in the context of a phase 1 or phase 2 study early on. That being said, there have been, through those randomized studies, some of which I mentioned, pretty effective standard treatments that have been developed. So the question, I guess, from a doctor perspective is how ethical is it to be administering investigational treatments to patients when we have really good standard treatments. Now, the flip side of that coin is the patient could argue, well, doc, you're telling me you have a good therapy, but my lymphoma is going to come back. So shouldn't I consider exploring, some newer options? And my answer would be, as long as the person is comfortable with that, I certainly have no problem. We at U of C just opened a phase 1/2 study of a combination that includes venetoclax, obinutuzumab, and a newer drug for patients who need treatment. So we do it. I think as long as the person understands that it's not a standard treatment, we don't know for sure if it's going to be as effective as standard treatments, I'm totally comfortable doing it.
Okay. Dr. Venugopal, a patient asked a question that you mentioned deletion 13 as being common in CLL, and they want to know, how would you treat a patient with deletion 13?
Yeah, deletion 13 is interesting in CLL because if you look at, I think I showed the graph, the FISH data, I showed you that 17p is having the worst prognosis in terms of duration of remission, whereas the patients who have 13q deletion, the curve is even little above the patients who have normal chromosomes. So in other words, it is considered a favorable chromosome abnormality if it is the only abnormality in the patient's cell. Having said that, certainly that's a prognostic, patient-wise it is good, but in terms of treatment, there is no specific treatment option based on the fact that you have deletion 13. It will be treated just like others who have normal chromosomes or favorable chromosomes, but there is no specific target based on deletion 13.
Dr. Kline, you mentioned on one of your last slides about bispecific antibodies. What the heck are bispecific antibodies, and can you give some examples, and are they effective for non-Hodgkin's lymphoma?
Yeah, so bispecific antibodies represent a type of immune therapy, and these come in slightly different flavors and forms, but generally the idea is that this is sort of a bivalent structure. One end of the antibody binds to a B cell, a cancer B cell. The other end binds to a T cell and sort of juxtaposes or puts those cells next together. At the same time, the part that binds to the T cell stimulates it or activates it. And so what happens is the T cell and the B cell are next to each other. The T cell is activated and is now able to kill the B cell, independent of its own natural specificity. So very clever idea. These are medicines that are given through the vein. They're not a cell product like the CAR T cell therapy, but the idea is roughly similar. Some of the side effects are the same. And as I mentioned, these drugs have been around for a while. They've been approved for a type of B-cell leukemia called B-cell acute lymphoblastic leukemia now for some time. And I feel like for years they were sort of ignored in the lymphoma space. I myself was not super enthralled with them. Blinatumomab is the one I'm speaking of largely. But there are now many drug companies that are developing these bispecifics, and they are effective. There are too many to list, but they all work pretty much the same way. And they have very good effectiveness, particularly in low-grade lymphomas like follicular lymphoma, where the response rates are upwards of 60 to 80%, depending on which one you're looking at. And the duration of response is also pretty remarkable. And now in aggressive lymphomas, diffuse large B-cell lymphoma, for example, they're also effective. The response rates are a little bit lower, but they work even in folks sometimes who've relapsed after CAR T-cell therapy. So, I think we're going to see some approvals of bispecific therapy within the next year. These are a little bit cumbersome to administer. They do cause some side effects, so sometimes they need to be administered in the hospital. They require, many of them, sort of stepped up dosing, where you start with very small doses to sort of mitigate or reduce the risk of some of the side effects and then go up on the dose. So they're a little bit challenging to administer, but yeah, they're very effective, and I think they will become part of the standard armamentarium. I don't think they're quite as effective as CAR T cells, but they're also less toxic. So it's going to be I think a game changer in the next 12 months.
Okay, so we're getting a number of questions, both for CLL and I guess also mostly for follicular lymphoma. And the question is, I keep relapsing. How long can I keep going, or how many different treatments can I get? We'll start with you, Dr. Venugopal first, and then Dr. Kline as well.
Well, I mean, when we only had chemotherapy in the past, there used to be certain numbers we used because, you know, with each chemotherapy, the time of disease control and the rate of disease control comes down. And that used to be something, you know, we knew with chemotherapy, whereas with these novel agents, you saw that many of them work in many different ways. And that principle really doesn't apply. You know, just because the initial treatment didn't work doesn't mean that the second treatment may not. In fact, the second treatment may have even a longer response compared to the first one. So that's why I don't think I would be able to give a, you know, nice graph saying that, yeah, with each treatment, your response and the duration is going to come down. No, I don't think so. With the novel agents, I think the trick is to pick up. First of all, you need to use treatment keeping in mind that sequencing, because it is very important that when you do a treatment or when you pick a treatment, you don't want that treatment to compromise your future treatment options. It has happened in the past, it should not happen. So if you're carefully sequencing the treatment, you should be able to get benefit from subsequent treatments equally or sometimes even better. That's the best answer I can give.
Yeah, Vinu, I agree entirely. I think, you know, every year, or seems like seemingly nearly every year, some new drug is approved. You know, I showed you a slide that indicating that, you know, 3 to 4 new drugs or drug combinations have been approved for diffuse large B-cell lymphoma. I know we're talking about CLL and follicular lymphoma, but the same is true of those lymphomas. And so, you know, we always seem to have another option to offer folks. Sometimes when people continue to relapse despite good standard therapies, when we consider more aggressive treatment options, those with potential curative intent, like stem cell transplant, donor stem cell transplantation, CAR T-cell therapy. But again, here's another good opportunity. If you've had 4, 5, 6 treatments with your regular oncologist, maybe time to think about meeting with somebody like Dr. Vinu, for example, who might be able to offer you new treatment options, clinical trials, in other words. So that's something also to keep in mind.
Okay, we only have a few more minutes, and there's, of course, many more questions. So we're going to do this Kramer style. We're going to have the lightning round. So here's one for Justin. I'm 92 and I've been on Imbruvica for 12 years. Is that still my best option?
If you're on Imbruvica for that long and it's not causing a lot of side effects, the short answer is yes. Don't stop.
Okay. And then the last has to do with COVID-19 vaccines. And we have 3 questions here. One about adverse reactions. I have no antibodies post-vaccination. What should I do? And I'm taking ibrutinib, and I had severe COVID-19 in April 2020. So what is your approach to for your diseases, for the patients to prevent and or treat COVID-19? Dr. Venugopal.
I think first I had to state that I encourage COVID vaccination for everyone. The exception I can think of is patients who have serious allergic reaction already had. So otherwise, I encourage everyone. Second, yeah, it is ideal that they get I'm talking about CLL. Ideally, yeah, they should get it when they are not on treatment, especially with an anti-CD20 monoclonal antibody. I do have several patients who have 0 spike antibody is the antibody that works against COVID. And all the ones I identified are patients who have been on treatment, which includes a antibody like rituximab or obinutuzumab. So I think that certainly is a concern. If there is a patient with new diagnosis, they can wait for some time to start treatment. I would encourage them to take the vaccination and then start treatment later on.
And the booster.
Obviously.
And the booster. They should get all 3 doses. What happens if a patient of yours or yours, Justin, gets COVID-19 infection? How do you approach it? And what do you tell them?
Well, sure. So, I mean, if it's a more serious infection or more symptomatically serious, then oftentimes they'll be admitted to the hospital and, receive steroids and remdesivir and so on. But for most patients, even those with CLL or low-grade lymphomas, these folks have typical cold symptoms or maybe a little bit worse than cold symptoms. I think the first thing that I think of is getting them in for the monoclonal antibody therapy, which can significantly reduce their risk of needing to be admitted to the hospital for more severe COVID-19. Otherwise, quite honestly, we keep a close eye on them. We hold their therapy just keep in close contact, because if symptoms worsen, then we want to be on top of getting somebody admitted for more intensive therapy. But the monoclonal antibody treatment is effective, and that's what I typically think of initially.
I agree 100%. And for those out there, you need to know that once you get a diagnosis, you can get the monoclonal antibodies, but only up to 10 days after symptom onset. Don't call us 11 days or 12 days. We can't get it for you because it's still under an emergency release from the FDA. So you get symptoms of COVID, don't delay, get your diagnosis made. And once you have your diagnosis, then call and do get the monoclonal antibodies. They will give you instant immunity. And we've seen a variety of patients literally with symptoms get better within the first 24 to 48 hours. So do indeed push your doc. If you're not getting anywhere with your doc, find somebody who will do that for you. So with that, I'm going to end and thank both of the presenters tonight, Dr. Venugopal and Dr. Kline. It's my privilege to moderate this, which means that I get to listen as well and not have to prepare slides. So there is a little bit of an advantage. They gave you great information, and hopefully the questions help clarify some of the areas. As always, this presentation will be available online.